Good morning. Thank you, Emmanuel, Steve. We have known each other for a few years as department chair at that time. And I see more Canadian colleagues during the COVID here in Dubai rather than in Edmonton, University of Alberta or Montreal. So we're glad to report my personal opinion about future psychiatry, especially after the COVID and explosion of AI and machine learning. So today I want to give a brief discussion about the future psychiatry, the role of technology. So I want to cover three aspects. First, talking about future we could not afford without talking about a little bit history in the past. And also talking about what challenge we have currently in the field of psychiatry. And then later on talking about potential the impact of technology and some thought for the current issues. So it's not surprising. I always use this slides just to show how important the mental health. It's not the how much suffering, but also how much social cost. So mental health patient always young, productive age, not like cancer, heart disease. Normally it's a retirement age disease. And certainly quality of life will be impacted, but for mental health, it's most young, productive period of life related to society, work, especially about family. So we really have a task, daunting task in front of us. So looking back, the psychiatry, right now we talk about mental health with the technology, but the psychiatry also always a part of a religion, culture, and civilization. We can see the Greek philosophers at that time talking about mental health is not only the problem, also came with the creativity of artists. You can see those famous artists not only in the Muslim and religion background, also in the Catholic, mostly in European history, and the artists almost always made up history or real history have some creativity related to madness or the depression. And all those artists and musicians have a lot of story about suicide, melancholy or depression or manic. And here's artists with bipolar, very famous, and musicians. And then early, actually, talk about technology, we could not avoid the ECT. We still use that time is technology, ECT. So more than 100 years, ancient Romans actually use ECT already. We do not have a way to generate electricity. Already use ECT. So Mediterranean use the electric fish to emit up to 500 volt, very small current, and to induce a seizure. That's a ECT, that's a technology that time. And also the lithium. Lithium, this word comes from fluid from stone, right? Called lithium. Actually, lithium, that time we do not have a concept lithium. Lithium is reported around 1773 year of that time, a few years, 400 years ago. But right now is the second century of AD. They already use lithium to treat bipolar that time. And certainly we always talk about environment treatment. Here you see early Islamic hospital as the pioneer to establish good environment treatment. And you can see environment is called a physical treatment. Right now we call it a novel intervention. Actually, all those physical treatment come from a different kind of environment, current, magnetic, light. And also here, this is our kind of a dark age of psychiatry, demonology. And also there's a DSM-0 that time. What that called the DSM-0, there's a manual how to hunt witches in psychiatry that time. Yeah. And also we have a neurosurgery at that time, we call trepanation, just make sure the devil spirit can come out from the hole we can drill. So discharge, just like in medicine, the early days, most effective medicine actually at that time is bleeding. right? So that time we use the hoe to bleed out the evil spirit. So that's a neurosurgery, that's a technology. And phrenology, that's a neuroimaging, scanning outside, not inside. So we look at some people, the shape of the head, and can decipher what's your personality. That time people certainly not political correctness nowadays, and we decide this group of people, ethnic population is inferior, and that group is the much better. So even Hitler used quite extensively with those so-called scientific theory. Yeah. So talking about the treatment, we always talk about biological treatment. That means the drug. But before we have effective medicine, and we see the malaria treatment that time. So that time we already know neuroinflammation related to psychiatry. And also right now we talk about flora or the gut, the bacteria in our intestine really influence the mental illness. So we can see that time malaria is kind of an infection, parasites, and the treatment is use the chemical, okay, and then use the fever. So that's a lot of anything today we can trace back to the history of medicine. So then come to treatment. Treatment in psychiatry always say we treat problems with the talking therapy. We treat symptoms with medication. So pills is for symptoms. Talking is for problem. So without talking any kind of psychotherapy, actually we already have psychotherapy for a few hundred years or even more than that. Always have psychotherapy already. Grandmother, the tribe chiefs, and shamans, all those are psychotherapy. But in the Western country, we all thinking the father of psychotherapy is Freud, right? But let's say yes, okay, that's a modern psychotherapy. And then we're talking about mesmerism. So the very interesting that's RTMS come from. So they use a magnetic influence to people. But before they do that, they give people drinking some iron water, so fluid, so you can move around the magnetic around the people. So that's a French kind of invention that time. And also the hypnosis also come from that. But only one people can do that work at that time. So it's a pseudoscience. And then surgery get into psychiatry. Surgery. So what that means, so they say hysteria. What means hysteria? Because the worm is wandering around. What do you do? This causes neurosis, because anxiety is the best way to take the worm out. So to treat neurosis, or get people pregnant, so the worm not going to wander around hysteria. So that's our psychiatry development. And then there's a very good fourth treatment called rotational therapy. And some industry company make a lot of money. So get people have the G. So, but sometimes we send people to space station right now, but we do not send the depressed people there. But you can see the G force is also a kind of a therapeutic modality. You see the people spinning, that's a treatment for neurosis. And certainly the infection is a part of psychiatry. So where is the most feasible place the infection starts from? Tonsils, right? Spleen, uterus, what do? You take those out and people get better. And then they use a statistical analysis at that time. The people died don't count. People get to count. So the insulin success rate is very high. Actually, 40% people will die. So that's the statistical analysis at that time. And then insulin shock therapy, and we used that for 50 years, and 10 people died, and then stopped. Come to 20th century, and lobotomy got a Nobel Prize. I'm thinking in the next few years, some people are doing AI, we got a Nobel Prize, but had to be revolutionary treatment for disease. ECT got a Nobel Prize, okay? And then come to psychopharmacology. That's the promising come to revolutionize. And also we send all the patients to community. And then there's suddenly so many people homeless. So deinstitutionalization is good revolution, but same time in modern societies, they really create a population of homeless on the street. So the psychopharmacology is a revolution, and we can see antidepressant and then MAOIs, that's a start antidepressant, and benzodiazepines, and that's the history before, I'll say before 50 years ago. So I finish, that's a history quickly, about 200 years or even 2000 years. So what's the most revolution in last 50 years? So we talk about three revolutions. First is genomic revolution in psychiatry. We're thinking, when I was a graduate student, we talk anti-sense therapy. We map out our gene sequence. We know which gene decides which disease. We use anti-sense get in. We cure any disease at that time. Everybody believe that. But I think artificial intelligence also is kind of hype. Right now, we really have to do the work and then focus. So in genetic revolution, we can see in 50 years ago, there's not many genes related to mental health. We only know it's related genetically. And then right now, there's some particular gene with a very strong correlation already in the last 10 years. But the genomic revolution is to talk about connections. It's not necessarily one transporter like a DNA dopamine receptor, but the most important is connections, network. That's the psychiatry. So what we have learned from genetic risk, not cause, complex, not simple. So genetics don't follow DSM. That's what we learned. We know that 200 years ago, but with all the data, we still come to a better, justified, same solution. But talk about neuroscience get very fancy. We even can locate our GPS neuron in the brain, which neuron light up when we see the same thing. If we meet the same person, there's some neuron light up. Such like I met some friend today, the neuron light up. Because I haven't used that neuron for the last 5 years. I haven't seen that friend in 5 years, okay? But mapping the human connections is most important. But if we're talking about connection, there's a structured connection, neurotransmitter connection, and a fiber connection, magnetic connection, different kind of connections. So talk about connections, what do we learn? It's a mental disorder is brain disorder in neural connection. And the circuits really matter. So individual difference are profound, and plasticity give us hope. So the brain is dynamic, it's fluid. So we can have a window to intervene by artificial intelligence, by electronic psychotherapy. Okay. So this is the past and current state. But what we do, I just use one example about what we do with the diagnosis. And right now, artificial intelligence, machine learning, different parameter, the biomarkers. But with the diagnosis of depression, what do we do? We know so much, but in clinical practice, major depression have 256 combinations. What that means, we have two symptoms, we have one, loss of interest, depressed mood. And then we have a whole bunch of different parameter, different combinations. So we can develop 256 combinations to diagnose depression. We're doing symptoms is really late manifestation of brain disorder. Just like people have a fever, and then we say it must be infection, viral infection or bacterial infection. But we only measure and treat fever or temperature. We don't know what causes depression physically. The treatment focuses on symptoms, not cure. So that's the current status. That's the current state. But what kind of treatment? Treatment is fragmented. We have a medication versus psychosocial. And most focus on symptom control and access really limited, and adherence poor, on-site late. But the problem is medication have a rather little innovation in the last 30 years. And the psychotherapy does doses, duration. We don't know what's going on. So if we give a psychotherapy, what's the dosage we should give? What's the duration we should use? It depends on the therapist, not depend on the patient. So the treatment depends on provider not depend on patient. So if we see the cancer patient, it doesn't matter what kind of therapy is a surgeon, just like we have to treat it with a standard protocol. But in psychiatry, depending where you walk into the private clinic, is this person really focused on psychotherapy? So there will be more psychotherapy. If this person is really using medication, will be more medication. But certainly the best is combination, right? So that's the current situation. Okay, so let's talk about technology transform mental health care, both in depression or anxiety. So that's Dr. Tom Insel, people probably know him. He's a really thought leader in the United States and he's the director of AMH and have an idea, talk about technology, how to promote mental health and he want to sabotage DSM-4. That's his idea of, with the last 10 years. So we had a lot of communication. So area of acceleration, machine learning, that start a while ago, all those kind of things. I put this picture because the inventor or the PI in this picture, in this program is come from University of Alberta. So that's why I want to put this picture. Actually, AI is very advanced in Canada. Montreal is the leader, and Toronto, and also University of Alberta. So we have 3 hubs in Canada about AI, especially AI and health. So we talk about the digital phenotyping. That's the new concept we do right now. We call it digital phenotyping. It's a passive, moment by moment quantification of individuals' level, the human phenotype. In situ, use the data from smartphone, other personal data device. That's called phenotyping. Before, we always talk about genotyping and biomarker. Right now, we really focus on digital phenotype. This conference is about. So we know we all equipped or link or smart app quantify self. Whenever, just like Professor Steve say, he got a green kind of light, can go anywhere with his smartphone. And for us, we have to take a PCR to go anywhere in your universities. I'm a plan to visit a few medical schools in next week, but I was told to have to take PCR, otherwise not going to let it in. So I had to take 2 PCRs because I visit a few medical schools in next week. So digital the phenotyping is a very exciting ideas and so much potential. But also so much concern as well. So the digital there's an active part, there's a passive part. So different data. Okay. So the most data used for actually is a passive part. Okay. So here's the whatever the Apple will produce or smartphone company will produce, all those kind of computer stuff. There's some kind of data they collect. Social media, communication, information, and entertainment. And here's the research showing how to do about the data. Which data we use most is sometimes it's called the data communication. And also we call the data contamination, okay? So the machine learning will be so important which data we need from the noise. The noise is not only from different data, but the same data, what time you use as a noise, what time you select as a signal. That's the major problem. Example, here's the deep learning with all those data and with all those formula, logarithm, and then they come to say, yeah, you're depressed. Oh, no, you're depressed. Or no, you're not depressed or manic. So different kinds of treatment have different kind of treatment data have a different kind of result. It's a statistical analysis. So they're not going to replace psychiatrists or treatment team, or the AI not going to replace human touch, but only release psychiatrists or therapists more time to provide care, human touch. So they call deep learning. And what kind of passive data do people collect? And we can see here is the different categories, some GPS, some typing skills, some voice, some movement, and all those different data collected for different parameter control. So here's a different people collect a different kind of data depending on the purpose. Yeah. So digital biomarker or digital phenotyping is with the cognitive function is most important. And the colleague just a few minutes ago showing the Alzheimer initial diagnosis with the digital biomarker. And that's very important as well. So the most important is the touch screen inputs as the biomarker. How often, how quickly your typing pattern change, and where you check, where you look, where the app you use, and then later on certainly there's some different kind of pattern detect in different particular population, different community. So there's a lot of analysis to do. It's called a biomarker, okay, but also called a digital phenotyping. Recently, we also use a lot of, there's a lot of app developed about voice recognition. So voice recognition, we certainly use a Palm Portal can have different language, but this is not content dependent. It's mood dependent. So if I'm a little bit excited today talking to you, but if I'm so tired with jet lag, my mood would be different and the voice is different. So the one way is to detect the content. Another way is to detect the mood and the frequency of your talking, high pitch, low pitch, compared with the past. So that's very powerful and also a lot of potential for voice and the facial recognition. The facial recognition certainly not normally in airport or whatever, but right now we detect, are you real happy? Are you fake? And those kind of things. So that's a lot of. So the benefit of digital phenotype is longitudinal in situ monitoring, real time, cheap, scalable solution. Idea to complement e-health, telehealth, can be preventive or reactive, okay? And can track and maybe part of people's electronic medical record. Certainly the shortcoming we always talking, especially in Canada, and we have a very strong consideration about ethical dilemma, confidentiality. So the shortcoming also have hardware limitation, contamination of the data, different kind of operating system, and standardization of approach, high noise, certainly a lot of noise, and needs human interpretation for foreseeable future. In the end, just like X-ray, right now have a lot of digital tools can predict or even report for radiology, but in the end, have to be people touch. So I can see there's AI will create more need and more niche for psychiatrists. It's not going to replace psychiatry. There's kind of a public opinion thinking AI will replace radiologists, pathologists, but they'll actually will double the workforce for psychiatrists rather than reduce the psychiatrists. And certainly ethical dangers of digital phenotype, and especially with the good hackers, they can hack into anything. And you can see it's very dangerous. And if you have a profile of anybody and at a fingertip, so there are a lot of things that they can reverse or reprogram your brain. What a dangerous thought about that. So where we are, the digital evolution. So we are just at the beginning of using digital tools to map and understand behavior. So digital phenotype is a shiny emerging technique with great promise. So the combination of a sensor, big data sets, and machine learning will likely transform how we measure and describe behavior. So that's the beginning of today. And mental health and dementia will be the new frontier for therapy, wearable AI monitoring and innovative intervention. So the mental health and Alzheimer cognition, that will be the measurable parameter, and just like a thermometer about fever infection. Okay. So that's where we are. So this is my last slides. not talking about how to read out what we have, normal, non-normal, but also how to form a loop and intervention. You see, today, this afternoon and tomorrow, there's a lot of talk about intervention, innovative stimulation, intervention. But here is a very kind of a grandiose and prediction, brain computer interface. So that will be the next generation or next revolution in psychiatry. We only try to read out the mind right now and then try to influence the mind. But right now we try to use digital and feedback and try to treat human behavior and also neuronal function. So that will be the best revolution we'll witness in next 5 years. But I don't think Elon Musk will be the only one thinking about this way. He's really thinking neurology more. Neurology, sports, competition, performance, about that part. But we are here thinking more cognition, emotion, quality of life, and real highest level of health is mental health. So we are here so proud of looking into the near future and far beyond what we can dream of in the next few years. Thank you very much.